I would like to introduce Dr. Thenappan. Thenappan, he's from University of Minnesota. He has been an expert in pulmonary hypertension and right heart failure. Uh, Thank you, Dr. Thenappan. Thank you for joining us.
It's a pleasure to join you.
A few questions I'd like to ask you today is related to what is ongoing currently in the pulmonary hypertension therapy. Is there any new studies that is ongoing?
As you know, pulmonary hypertension has really grown in the last 15 years, and the field is really active. And there are multiple pathways in which the field is active. So, to summarize them, one is usually like in pulmonary hypertension, or when I say pulmonary hypertension, I refer to pulmonary arterial hypertension. The standard therapy would be goal-oriented therapy. You start with one drug, and then once the patients fail on one drug, you go for the second drug. So now there's more and more evidence saying that we should be doing upfront combination therapy, like you treat cancer. You treat cancer with multiple drugs at the same time. So you combine drugs which attack multiple pathways. So there's growing evidence that dual upfront combination therapy is more effective than monotherapy. Similarly, upfront triple combination therapy in a very small series was recently shown to be effective. So on the other lines, there's prostacyclin is the best drug so far for pulmonary hypertension, and it is currently limited because it has to be given intravenous or subcutaneous or inhaled. And last year we have an oral prostacyclin approved, and it will be interesting to see how the field evolves. You know, the ultimate goal would be, instead of intravenous, can these patients be treated with oral therapy?
Do you, during the current ACC, do you come across any new studies in the pulmonary hypertension?
I'm not sure about the ACC, but in the last year there are several studies published, and one is called the Ambition trial, which is published in European Respiratory Society in September of last year, which showed that dual upfront combination therapy with ambrisentan and Adcirca or tadalafil is much better than monotherapy. So that's one of the recent trials. And there is another trial called Griffin trial, which looks at the prostacyclin receptor agonist called CELSI-PEG, and that's also like the initial abstract data is presented, and it's very encouraging. Those are the ones I'm aware of.
What are you currently working on at your institution on pulmonary hypertension?
So we are very much interested in the right ventricle. Right ventricle is the cause for mortality in these patients. So right ventricular failure is the predominant predictor of mortality. And so in our institution, we are very much interested in developing novel therapies for right ventricular failure in pulmonary hypertension. And one of the drugs we are involved is cross-purposing or repurposing beta blockers for RV dysfunction. So far, the dogma in the field is beta blockers are contraindicated or actually not safe in patients with pulmonary hypertension because they are heart rate dependent with a fixed stroke volume. And hence, it's not safe to use beta blockers. However, preliminary retrospective studies in human patients who are taking beta blockers for some other reasons, and also preclinical animal studies suggest that, in fact, beta blockers may be effective in patients with pulmonary hypertension. There is an initial small experience of 6 patients from a group in Richmond, and also which showed that actually, in fact, carvedilol, is safe and effective for right ventricular dysfunction and PH. So we are evaluating an investigator-initiated phase 2 trial looking at carvedilol for improving RV function in patients with pulmonary arterial hypertension, in addition to your regular PH-specific therapies.
How do you see the future of pulmonary hypertension? And do you think the pills will be replacing all the drips?
It's a $1 million question, and I think that's the holy grail. You know, the ultimate aim of this field is, right now we don't have a cure for pulmonary hypertension. All the drugs we have currently control pH but never cure. So the goal for in 10 years would be to find a pill which would cure pulmonary hypertension. So more than converting from IV to oral, we should keep our bar high and look for a drug which could cure pulmonary hypertension. And at the same time, I think there is a genuine interest in improving right ventricular function, and can we use mechanical circulatory support for right ventricular failure. The field is very, very, very in its early stage, but that I see that in the future.
Last question from a fellow's perspective. Do you think there should be a dedicated training for pulmonary hypertension or still should be combined with heart failure during the training?
I don't know. I think at this time and point, it's should be combined with advanced heart failure. I think can it be on its own? You know, it's my personal opinion that it's like it should be part of advanced heart failure and transplant. I think it really makes a good blend. You know, I was very fortunate to be trained with really good mentors in field of pulmonary hypertension as well as advanced heart failure, and having those two knowledge skills, it really helps me understand the disease process and better serve these patients. So I think combining them would be much more stronger than having them individually, I think.
At the end, I would like to thank Dr. Thenappan for his time, who's from University of Minnesota and with expert with pulmonary hypertension and RV failure. And please, if you have any more questions or any more, you'd like to see more blogs, go to www.youtube/fitonthego.